Thank you so much, Dr. Satapathy, for the kind introduction, and it's a great pleasure to be with you guys today. Again, my apologies about the technical glitch, but hopefully we can just advance the slides. So my topic is to tell you about the management of NASH, and it's really exciting times. We expect that 2023 will be the year where we have the first FDA-approved NASH medication, and this is going to change everything we do in terms of patient identification and risk stratification and making therapeutic decisions. So these are my objectives for today. First, I'm going to discuss updated data on the prevalence of NAFLD and NASH and the use of non-invasive tests, we call them NITs, to risk stratify patients. And then I will describe the therapeutic landscape for NASH and what's coming your way in the very near future. So we need to be ready because this year is the year. Next slide. So I want to make it clear that the target population for pharmacologic treatment is not everyone with NAFLD within the NAFLD spectrum. So we really are focusing on patients with what we call fibrotic NASH. So they need to have enough disease activity to classify them as NASH in terms of steatosis, inflammation, ballooning, and typically having a NAFLD activity score of 4 points or higher. And then they need to have significant fibrosis defined as the presence of F2, F3. Next. And again, this is the target population for the new therapeutic agents, patients with fibrotic NASH, so NAS of 4 or higher and F2 or higher. Now, in terms of updated prospective data on the prevalence of NAFLD and NASH, this is from a paper we published in the Journal of Hepatology 2 years ago, where we offered middle-aged adults in San Antonio, Texas, the opportunity to learn more about their liver health when they presented actually for screening colonoscopy. So these were individuals without any known history of fatty liver disease or viral hepatitis, no excessive alcohol consumption, and no known history of chronic liver disease. Again, they came for screening colonoscopy, and we offered them a state-of-the-art MRI PDFF to quantify liver fat. If they had 5% or more fat on the MRI, we classified them as having NAFLD, and then we offered them a liver biopsy to diagnose NASH and the stage of fibrosis. And to our surprise, we found NAFLD in 38% within our cohort, so this is higher than the national average, which is around 25 to 30%. But more importantly, we found NASH in 14% of the cohort. Again, this is biopsy-proven NASH, and previous estimates estimated that in the general population, NASH is present in maybe 5-6%, but we found it in 14%. Of course, this is, a cohort in San Antonio, Texas, enriched for Hispanic ethnicity, but this was definitely higher than what we previously thought. Next slide. Next, we did subgroup analyses for high-risk patients. Next. So when we looked at Latinos, Hispanics, we found NAFLD in 55%, and more importantly, NASH in 25%. Next. When we look at patients with type 2 diabetes, NAFLD was present in 70% and NASH in 36%. Next. And then when we looked at patients with several risk factors, including Hispanic ethnicity, diabetes, and obesity, it was almost a given that they're going to have NAFLD at 92%, and then almost half the patients had evidence of NASH. So again, definitely the presence of NAFLD and NASH are higher in certain at-risk groups, such as Latino ethnicity and patients with type 2 diabetes. So we do have a problem because we estimate that we have about 95 million adults with NAFLD in the United States and only 7,500 hepatology providers. And this includes all transplant hepatologists, gastroenterologists that take care of liver patients, and APPs, advanced practice practitioners. Next slide. So we need a simple way to rule out the presence of fibrotic NASH by primary care physicians that is cost-effective. Next. Next slide. And the reason why we focus again on this, significant advanced fibrosis, because we've had several studies showing that the risk of severe liver disease, so developing cirrhosis, liver-related complications, increases significantly once you reach that F2 fibrosis, significant fibrosis, and the same is true for liver-related mortality. Next slide. Let's move to the next slide. And next. Okay, so we have several ways to rule out advanced disease. We divide these into serologic markers, including simple scores. And the one I want to explain today is the FIB-4 index. We're discussing these simple scores that all of you can calculate in your clinics, and this is the FIB-4 index. It has 4 simple variables: age, because older patients are more likely to have significant disease; AST to ALT ratio, because we know as the disease advances, your AST starts going higher, and eventually the AST will become higher than ALT, even if you don't drink any alcohol. So this is really just a sign of progression of the disease. And then your platelet count, which goes down as you progress to cirrhosis. So you enter these 4 values in an online calculator, and you get a FIB-4 index. If it's less than 1.3, very less likely to have advanced disease. So these are patients you can keep in primary care. If your FIB-4 is more than 2.67, that indicates high probability of having advanced disease. These are patients that need to be seen by a specialist. And then you have about 30% of patients that will be in the indeterminate zone between 1.3 and 2.67. And in this case, you need to do another non-invasive test, or NIT. Next slide. The second serologic test I want to discuss is the enhanced liver fibrosis, or ELF test. This has 3 biomarkers in it: hyaluronic acid and procollagen 3 as markers of collagen synthesis, and then the tissue inhibitor of metalloproteinase 1, or TIMP1. This is a marker or extracellular matrix repair inhibition. So we actually measure these biomarkers, and then you get an ELF score. Next. This is the calculation for the ELF. No one needs to memorize this. Next slide. And this is how we interpret the ELF. So if the ELF is less than 7.7, this indicates the absence of significant fibrosis. So you can have NASH, but typically it's F0, F1, but definitely not F2 if you're less than 7.7. If you're more than 9.8, between 9.8 to 11.3, this is your F3 fibrosis. And then more than 11.3, this is cirrhosis. Between 7.7 and 9.8, this is kind of like the indeterminate zone, typically consistent with F2 or higher. Next slide. And then we have several imaging tests that could be available in a primary care setting. These are, again, ultrasound tests, including the Fibroscan machine, and we have different iterations of the Fibroscan machine. The one we utilize the most is the Mini 430 system. There's the Velicure machine, and this is a different way to induce the mechanical shear waves in the liver, and it gives you 3D visualization of the liver. And then, to an existing ultrasound machine, you can have also RF and shear wave elastography. Again, I think in almost every radiology department now, there is a way to determine liver stiffness. So even if you don't have access to a Fibroscan machine, make sure you ask your radiologist if they have a way to determine stiffness. Next slide. This is how we interpret Fibroscan. Very simple. You get 2 numbers. One is the CAP score, controlled attenuation parameter, which reflects steatosis. More than 275 typically indicates the presence of significant steatosis. And then we look at the transient elastography, kilopascal measurements, and less than 6 indicates no fibrosis typically. And then you can see the cut points for F1 all the way to F4 cirrhosis. Next slide. So we have now several algorithms that help primary care physicians risk stratify their patients and identify those at risk for having significant disease. This is the AGA algorithm published in 2021. Basically, you take patients at risk for NAFLD, including those with type 2 diabetes, metabolic syndrome, elevated ALT. You rule out excessive alcohol consumption, and then you calculate the FIB-4 index. FIB-4 less than 1.3, as we mentioned earlier, this is low risk. You keep in primary care, and focus on a lifestyle intervention, optimizing the management of metabolic syndrome, and then you repeat the test in 2-3 years. FIB4 more than 2.67, you send to a hepatologist or specialist. Between 1.3 to 2.67, this is indeterminate. This is when you need to do your Fibroscan. If your liver stiffness is less than 8 kPa, this is low risk patient, and basically more than 8 kilopascals, you send to a specialist. Next slide. So we actually wanted to assess the impact of applying the AGA algorithm on the United States population. So we utilized a nationally representative database called the Enhanced database, where they did almost 10,000 Fibroscan on subjects from different socioeconomic and racial backgrounds. And we looked at patients that had diabetes, metabolic syndrome, or elevated ALT. We identified close to 5,000 individuals that had values to calculate FIB4 and had also Fibroscan done. We excluded subjects with excessive alcohol consumption and basically applied the algorithm using sequential testing with FIB4 and Fibroscan, and we utilized the same cut points that were proposed by the algorithm. Next slide. So what we found in the study that I presented at the last AASLD meeting is that by using this algorithm and just starting with the FIB4 index first, you're going to find that almost 3/4 of subjects would be classified as low risk and have FIB4 less than 1.3. And then by further using liver stiffness by the Fibroscan machine, you can reassure an additional 19% of subjects as being low risk and having a kPa value less than 8. So basically, by applying this AGA algorithm, only 8% of subjects will be classified as high risk for fibrotic NASH and will be referred to a hepatologist. So this is much more manageable than the 95 million individuals that have NAFL. Of course, FIB4 is not perfect. Fibroscan is not perfect. So when we looked at the subjects with FIB4 less than 1.3, we found that 12% will had Fibroscan more than 8 kPa, indicating that they may have more advanced disease that was missed by the FIB4 index. Next slide. Now, these were the simple scores that can be utilized in primary care endocrine offices, but we have more sophisticated scores that we will utilize in our hepatology clinic to increase the positive predictive value and make sure that when we tell a patient they have at-risk NASH, that we're confident about this conclusion. So we have some serologic markers, including the NIS4 test. This is not commercially available yet, so I'm not going to spend time on it. And then we have some imaging scores, including the FAST score, and I'll explain it in a second. And more recently, several MRI-based scores. So we have MR elastography that can determine the stage of fibrosis, corrected T1, CT1, which is part of the liver multi-scan. This reflects liver fibroinflammation. You have the MAST score that we developed that has MRE, MRI-PDFF, and AST, and MeFib that relies on the FIB4 score plus MRE values. So a lot is happening in the field. The AASLD updated guidance document that was published in 2023 mentions actually these new MRI scores. So that's a good read for you guys over the weekend. So the FAST score stands for Fibroscan plus AST. And basically in the FAST, we have the CAP score for steatosis, liver stiffness for fibrosis, and AST for inflammation. And then you get a score that ranges from 0 to 1. FAST score more than 0.67 indicates at risk or high risk NASH. Less than 0.35 indicates low likelihood of having at risk NASH. And then you have the indeterminate zone in between. This was developed in a UK cohort and has been validated in 7 international cohorts. So there's a lot of external validation with this. And we and others also have submitted some external validations outside of the original paper. Next slide. The next score is the MAST score, and this is something we published last year. Instead of using the CAP score for steatosis from the Fibroscan, we know that MRI-PDFF is a more accurate way to quantify fat. So in this score, we included MRI-PDFF for fat. And then instead of using liver stiffness on Fibroscan, we used MR elastography, which is known to be more accurate. And we still included the AST. And basically, we had the same thing, rule out zone, mass less than 0.165. That indicates the absence of high risk or fibrotic NASH. And then the rule-in zone, mass more than 0.242. Next. All right, so this was my spiel on the diagnostic tests here. How about management of NASH? Let's look at the current management options that are available today. Next. So when we think about how to manage NASH, these are the goals for management. Number one, we want to achieve liver-directed treatment outcomes, including NASH resolution, fibrosis regression, but also improvement in the non-invasive tests, including reduction in liver stiffness and fat and improvement in biomarkers. But it's so important not to be so centered just on the liver, and that we actually evaluate the effects of any intervention on every component of the metabolic syndrome. So am I inducing weight loss? Are we improving the management of diabetes? How about hypertension and dyslipidemia? And then the third category of outcomes we want to achieve is really improving hard outcomes. So reducing major adverse liver outcomes, we call them MALO now. So these include progression to cirrhosis and then decompensating events such as ascites, bleeding, varices, and then of course, liver-related mortality. And then it's also very important that with any intervention that we are looking at major adverse cardiac events or MACE, because we know that patients with NAFLD are more likely to die from cardiovascular disease than liver disease. And we have to take into account the cost of any intervention and then the adverse events that our patients may have to deal with. Next. So we know that weight loss through lifestyle intervention is very helpful for patients with NASH. This is what we call the weight loss pyramid. And you can see that losing as little as 3% of your total body weight will help reduce steatosis. But if you want to resolve NASH and improve fibrosis, you need to lose about 10% of your total body weight. So if you're at 200 pounds, you need to lose 20 pounds. The problem is that even in the context of clinical trials where you have access to the dietitian and people are calling you to remind you to adhere to the lifestyle intervention, only 10% of patients with NAFLD are able to lose that 10% total body weight. So that leaves 90% of subjects not able to achieve that threshold. So we need other ways besides lifestyle interventions that are provided by a dietitian or a physician. Next slide. And one of the limitations we have, at least in the United States, is that access to dietitians is very limited. We can only, provide 2 visits a year for our patients with type 2 diabetes through some insurance providers in the United States. And we know that for any lifestyle intervention to work, you need that weekly reminder and conversation to actually adhere to the lifestyle intervention. So we see an opportunity for what we call prescription digital therapeutics to scale that intervention and maybe provide access to the dietitian and exercise physiologist through a phone app. So these are a little bit different than your typical phone app that anyone can go to the App Store and download. These need to be prescribed by a physician for specific indication. These apps need to go a rigorous evaluation by the FDA, and they will eventually be FDA approved and hopefully covered by insurance, and they need to be monitored by a physician. Next slide. So this is actually a multi-center trial, randomized controlled trial that is looking at an app for type 2 diabetes, and this is sitting with the FDA now. So they had to do a conventional RCT. They randomized 669 patients with type 2 diabetes to the actual app called BT001 versus a sham app, and they received this intervention for 6 months. And they showed that actually by using the app BT001, a higher percentage of patients were able to reduce their A1C by 0.4% or more compared to the sham app. And there was a clear dose response between the engagement with the app, how many minutes a day you spend on the app, how many articles you download, how many recipes you download, and actually the improvement in A1C. So, you might be hearing more and more about these prescription digital therapeutics, and hopefully we'll have an FDA approval for type 2 diabetes. Next slide. And this is a proof of concept pilot study that we did at Arizona Liver Health with the digital therapeutic. This is an app specific for fatty liver disease. We included 22 patients with the NAFLD. They all had MRI PDFF to quantify liver fat. And you can see that about 45% had type 2 diabetes and 60% had hypertension. And we actually showed reduction on MRI PDFF after 90 days of using the app, about 3% from baseline. Next slide. And here you see a waterfall plot showing reduction in ALT in the majority of patients with using the app. And in fact, if you look at patients with elevated ALT at baseline, we're able to reduce their ALT by 23 units per liter from baseline. We have several studies showing that if you reduce your ALT by 17 units from baseline, this corresponds to improvement in NASH and NAFLD activity score. So this looks promising, but this is again a pilot. There was no placebo, and it was only 90 days. But we are looking now into doing a larger study that will include a sham app. Next slide. Of course, weight loss through medications such as GLP-1 agonists like semaglutide is a very effective way. This is data from the STEP 1 trial that led to FDA approval for the obesity indication. Patients lost about 17% of their total body weight. But what's also important is to notice in panel C, for example, that the majority of patients are able to lose 10% or more of their total body weight. So now we're at 70%, which is much better than the 10% that we can achieve with the typical lifestyle intervention. So by utilizing these medications, again, the majority of patients will be able to achieve that threshold of 10% total body weight loss. We have more data with dual agonists now with tirzepatide and maybe even a more potent agent for weight loss. And the field of anti-obesity medications is exploding. We have also some combination therapies. So more to come on these medications. Next. And then bariatric surgery is a very effective way to treat NASH. There was a landmark paper from France where they biopsied people at the time of surgery and then at 1 year and 5 years, and they showed improvement in fibrosis in the majority of patients, NASH resolution in 85%. But what I'm showing you in this slide is actually a paper that we published with colleagues from the Cleveland Clinic called the Splendor trial. This was published in JAMA in 2021, where we had 650 individuals that underwent bariatric surgery. They all had biopsy at the time of surgery, and we matched them to a non-surgical control. All these patients had NASH and F1 to F3 fibrosis. We did not include patients with cirrhosis. So in terms of major adverse liver outcomes, in panel A, there was an 88% reduction in developing liver outcomes from cirrhosis to ascites and variceal bleeding, encephalopathy. So very effective way to show actually reduction in hard outcomes from a liver standpoint. And then we also showed 70% reduction in MACE, so major adverse cardiovascular events. So very promising. I think bariatric surgery is a very effective treatment. However, we all know that unfortunately the majority of patients that need bariatric surgery, either they're not interested or they're not covered by their insurance providers. Next slide. So this is what I call the weight management spectrum for NAFLD. And as hepatologists, gastroenterologists that take care of patients with fatty liver disease, we should be familiar with this and be comfortable actually utilizing the entire spectrum. So we start with the traditional lifestyle intervention, but we have several apps that are available today for weight loss, and prescription digital therapeutics specific for weight loss and NAFLD should be coming soon. We need to be comfortable using anti-obesity medications. I prescribe semaglutide and tirzepatide in my hepatology clinic. They're not that difficult to manage, and we need to be comfortable using them in our NAFL patients without diabetes. I get a little bit more concerned when they have uncontrolled diabetes, so I like to, organize that with their treating physician, PCP or endocrinologist. But again, I use semaglutide very freely in my obese patients without diabetes. Endobariatrics, I don't have time to go over this, but some stomach balloons, duodenal mucosal resurfacing, and endoscopic sleeve. Most of these are not covered by insurance in the United States, so they're out of pocket, and this has been the major limiting factor. And then bariatric surgery, whether it's Roux-en-Y or sleeve gastrectomy. Next. Now, let me give you an update on the new NASH therapeutic agents. This is a very exciting area. As I said earlier, we expect that in 2023, we will have the first FDA-approved NASH drug. Next. Just a reminder that, again, when we talk about pharmacologic treatment, we want to reserve these medications at the moment for patients with fibrotic NASH, and we do not want to treat every patient with NAFLD with medications. So the focus should always be on a lifestyle intervention that induces significant weight loss. But for patients on their way to develop cirrhosis and its complication, once you get to F2, we may need a pharmacologic treatment, especially in patients that had diabetes metabolic syndrome for a decade or longer than that, and they've tried to lose weight multiple times. I think it is very wise to get them on medications before they progress to cirrhosis. Next slide. So in terms of FDA approving medications, we only have two endpoints that the FDA will acknowledge now in a phase 3 program. And they're both based on histologic improvement, which means you need to do your biopsy at baseline and then a biopsy at the end of treatment. The endpoints are NASH resolution, which means you need to have 0 ballooning on the repeat biopsy, and you can only have minimal inflammation, so grade 1 inflammation, or fibrosis improvement by 1 stage. So you go from F3 to F2, for example, and you cannot have worsening of NASH when you improve fibrosis. Next slide. In phase 2A studies, obviously, we don't want to do 2 biopsies before we have signaled that the drug is effective. So we utilize MRI-PDFF, and we know that reduction by 30% relative reduction from baseline for drugs that have a metabolic mechanism of action is associated actually with improvement in NASH and NAFLD activity score. As I mentioned earlier, also reduction in ALT by 17 units from baseline predicts histologic improvement. And then reduction in liver stiffness and liver fibroinflammation with tests such as MR elastography, Fibroscan, corrected T1, that also potentially predicts fibrosis regression on biopsy. Next. So we have a very rich pipeline. We can target every step of disease development and progression, from insulin resistance, lipid loading into the liver, all the way to anti-fibrotic drugs. And we have several drugs in development. I don't have time to go through all the mechanisms of action, but we have 4 drugs in phase 3, including semaglutide, resmetirom, lanifibranor, and obeticholic acid. And in the next few slides, I'm going to go over these very briefly. Next. So the first drug in phase 3, and this is sitting with the FDA now, with the PDUFA date potential approval June 22nd of 2023, is obeticholic acid. This is a synthetic bile acid. It's a modified chenodeoxycholic acid, and it signals through a nuclear receptor called the farnesoid X receptor, FXR, which actually regulates the genes involved in bile acid synthesis, but also it has pleiotropic effects within the liver and outside the liver, including effects on liver inflammation and fibrosis, and effects on lipid metabolism. Next slide. So obeticholic acid was studied in the phase 3 Regenerate trial that in the interim analysis looked at about 900 patients that had biopsy at baseline and repeat biopsy after 18 months of the intervention. That included obeticholic acid, low dose 10 milligrams, high dose 25 milligrams, or placebo. And what we learned in the Regenerate study, that actually there was a signal on fibrosis regression by 1 stage with the high dose 25 milligrams. There was no signal on NASH resolution, but they actually achieved one of the endpoints for FDA approval. Next. But unfortunately, there are several adverse events, including pruritus in 50% of patients and severe pruritus in 10%, worsening in lipid profile, including increase in LDL cholesterol, biliary events, and potentially some hepatotoxicity events. So based on the delta improvement in fibrosis and the adverse events, the FDA actually issued a complete response letter and denied FDA approval in 2020. Next. However, the Regenerate trial continued, and now we have more data that was presented at the last AASLD meeting. One thing they did is actually, instead of having one pathologist assess the slides for fibrosis improvement, as was done in the original analysis, they did a consensus pathology read where they had actually two pathologists that needed to agree before they took the final reading. And if they didn't agree, they had a third pathologist. And the idea here is that, sometimes the pathologist reading can vary. We have a lot of inter and intra-reader variability. So they wanted to make sure that whatever signal they saw on fibrosis was actually solid, and that's why they did this consensus method. And basically, they're able to replicate the same results from the original analysis. And you can see that the high dose 25 milligrams was significantly better than placebo. And the delta is almost identical, about 12% improvement from placebo. Next. And here they did this analysis where they looked at shift in fibrosis stage, and they focused on patients with F3 fibrosis. And they showed, number one is that with the high dose, there was 37% improvement by one stage of fibrosis compared to placebo. But they also looked at the percentage of patients that worsened, and they showed that with obeticholic acid, actually, there was a lower percent of patients that got worse at the end of treatment. Because we know not everyone is going to have improvement in fibrosis, and unfortunately, some patients will progress and go from, let's say, F2 to F3. So this is also encouraging, and it looks like actually the drug is even more effective in patients with F3 fibrosis than F2. Next. The second drug that actually has phase 3 data is resmetirom. This comes from three words, the name resmetirom, resolution of metabolic syndrome. And this is a selective thyroid hormone receptor beta agonist. So it turns out that the thyroid hormones T3, T4, they signal through two nuclear receptors. One is the receptor alpha, which is responsible for thyroid toxicosis and is highly expressed in the heart. That's the one we want to avoid. But the thyroid hormone or THR beta receptor, this is highly expressed in the liver. And actually, by selectively targeting this, you can decrease liver fat, you can improve lipids, and you avoid the thyrotoxicosis effects mediated by the but the thyroid hormone or THR beta receptor, this is highly expressed in the liver. And actually, by selectively targeting this, you can decrease liver fat, you can improve lipids, and you avoid the thyrotoxicosis effects mediated by the alpha receptor. So in a phase 2b study where we actually did MRI-PDFF at baseline at 12 weeks and 36 weeks, and then biopsy at baseline and 36 weeks, we showed the promising results. Next slide. So when you look at the high dose resmetirom, you can see that there was relative reduction in liver fat on MRI-PDFF by 42%. When we looked at the percentage of patients that achieved that 30% relative fat reduction from baseline, and remember, this is the threshold that predicts improvement in histology, 75% were able to achieve that threshold with the high dose resmetirom. And then when you look at liver biopsy data in patients that reduce their liver fat on MRI, 39% had NASH resolution. So we published this in the Lancet in 2019, and this was the basis for the phase 3 program. Next. So the MAESTRO-NASH study was the phase 3 trial. We only have the data in the form of press releases and presentations at smaller scientific meetings, but most likely this will be presented at the upcoming EASL meeting in Vienna. But this is the trial design. So basically, patients were randomized to placebo, high dose resmetirom 100 milligrams daily, or low dose 80 milligrams daily. They had MRI-PDFF at baseline, At week 52, same with liver biopsy, and they did several serologic tests, including LDL cholesterol. Patients needed to have metabolic syndrome and have F1 to F3 fibrosis with the focus on more advanced disease, and they needed to have 8% liver fat on MRI-PDFF. Next. So these are the baseline characteristics, and I don't want to bombard you with all these details. I just wanted to pay attention to the Fibroscan liver stiffness data. So you can see that the median KPA was around 13, 14. So this is geared toward more F3 fibrosis. And on biopsy, about 2/3 of patients had F3. So although the study allowed the inclusion of some F1 patients, you can see that that percentage was at 5%. 1/3 had F2, and the majority of patients had F3. Next. And these are the main findings. So first, we were able to achieve the NASH resolution endpoint. And with the high dose resmetirom, that was at 30%. Placebo response rate was only 10%. So there was a 20% delta from placebo. Next. And we were also able to achieve fibrosis improvement by 1 stage or more. And with the high dose, this was at 26%, and this was significantly better than placebo at 14%. And you can see that the delta here is almost identical to obeticholic acid. But again, obeticholic acid did not achieve the endpoint for NASH resolution. Here we see a clear improvement in terms of NASH resolution with resmetirom. Next. And then we looked at a key secondary endpoint, which is LDL cholesterol. And there was actually a significant reduction compared to placebo by 16% from baseline. So this is good news that we're not only improving the liver and achieving NASH resolution and fibrosis improvement, but also we are helping the metabolic syndrome and dyslipidemia. Next. The drug was actually very well tolerated. So the only 2 adverse events that were more common than the placebo arm include the diarrhea, which is typically a transient diarrhea that lasts for 6 to 12 weeks, and then it subsides. But this is something that if you're going to prescribe resmetirom, you should be discussing with your patients and maybe provide them with the strategy how to manage this transient diarrhea. And then nausea was also more common with resmetirom, otherwise well-tolerated medication. Next. We can skip the slide. This is just a summary. Next. The third drug I want to mention is semaglutide. This is a GLP-1 agonist. Was studied in a phase 2b trial that was published in the New England Journal of Medicine. Several doses, but one of the doses is the equivalent of the dose we use now for obesity, which is 2.4 milligram weekly. Here they did daily dosing, but this is a thing of the past. So now semaglutide is only utilized as a weekly dose. So let's go to the next slide. So I just wanted to focus on the high dose, which is the 0.4 milligram daily, which is almost the same as the 2.4 milligram weekly. And when we looked at NASH resolution, we found actually a high rate of NASH resolution in the 60% range. This was significantly better than placebo. But there was no improvement in liver fibrosis, which is probably related to the fact that semaglutide has no receptors in the liver. There are no GLP-1 receptors on the hepatocyte, for example. So the effects are mediated by weight loss, and then you hope that the liver will heal itself through the process of fibrolysis. But that may take longer time, and maybe that's why we did not see the effect on fibrosis. But I want you to note that in the middle panel, the fibrosis regression rate was at 47%, which is higher than both obeticholic acid and resmetirom. But the placebo response rate was very high in the study, also at almost 35%. But again, there was no signal basically on fibrosis, but there was a high rate of NASH resolution. There was potentially a signal on less progression of fibrosis with semaglutide. So very promising agent. What's good about semaglutide is that you're going to tackle every component of their metabolic syndrome in addition to their NASH. You're going to reduce weight, improve lipids, and improve insulin sensitivity. Next. So the last drug I want to discuss today is lanifibranor. This is what we call a PPAR agonist. You guys know that PPAR alpha agonists include fibrate medications, so they lower your triglycerides. PPAR gamma agonists include the glitazone medications, so they're insulin sensitizers and they affect adipose tissue metabolism. And then there's a PPAR delta that is expressed in the liver and decreases liver inflammation and potentially fibrosis. So lanifibranor is a pan-PPAR agonist. So it's a PPAR alpha, delta, gamma agonist. Next. And in a phase 2b trial that we published in the New England Journal of Medicine, we showed actually improvement in both primary endpoints. So there was resolution of NASH in 45% with the high dose lanifibranor, 1200 milligram daily compared to placebo. There was also improvement in fibrosis by one stage or more in 42%. And then here we also showed that patients were able to achieve both primary endpoints of NASH resolution and improvement in fibrosis in 31%. And the study was actually only 6 months of treatment, so this is short duration. Next. So these are the 4 drugs that are in phase 3. I just want to leave you with a few interesting abstracts that were presented at the last liver meeting. These are what I call jaw-dropping NASH moments at the liver meeting. Next. So the first study was actually looking at resmetirom, but here they looked at patients with well-compensated NASH cirrhosis. Remember, in the MAESTRO-NASH study, we did not include patients with cirrhosis. And so far, we really don't have much data on improvement in patients with cirrhosis. This has been the highest bar. Next. So this is the MAESTRO program. This is the clinical development program of resmetirom. And the study I'm going to discuss was an open label study where we included 180 patients with NASH cirrhosis. Next. And here there was no placebo. This was open label. So we divided the patients into PDFF less than 5%, which typically indicates what we used to call cryptogenic cirrhosis. It means that you have so much fibrotic tissue that there is not much fat left in the liver, but you still have NASH cirrhosis. These patients tend to have a more aggressive course, and then patients with PDFF more than 5%. And we didn't do biopsies, so we looked at fibrosis improvement on Fibroscan, but there was actually a signal toward improvement in liver stiffness on Fibroscan and change by 25% or more from baseline. This was achieved in about 45%. And then we also found that a good percentage of patients reduced their MR elastography by 15% or more. So again, for the first time, we have a relatively large study, 180 patients with NASH cirrhosis showing improvement. Compare this to the data with the reverse trial with obeticholic acid. This was a negative study, and there was no improvement in patients with NASH cirrhosis. So resmetirom is actually being studied now in a phase 3 trial in patients with NASH cirrhosis called the MAESTRO-NASH outcomes. Next. And there was improvement in several non-invasive tests, including reduction in MRI-PDFF, so reduction in liver fat, so the CAP score from Fibroscan, also for steatosis, liver volume, and also all the lipids, so reduction in LDL, ApoB, and triglycerides. Next. Efruxifermin is what we call an FGF21 agonist. For simplicity, FGF21 is a hormone produced in the liver, but it has effects in the adipose tissue. It affects the lipolysis process, which is a major source of lipid loading into the liver. But also it has direct liver effects, and it inhibits de novo lipogenesis, which is the process of converting glucose into pyruvate and then fatty acids. So efruxifermin is what we call a balanced FGF21 agonist that works on both lipolysis and de novo lipogenesis. Next. So in the Harmony phase 2b trial, efruxifermin was very effective. We show a reduction in fibrosis by one stage in 41% and a 21% delta from placebo. So this is very encouraging. More importantly, there was resolution of NASH in 76%. This is the highest NASH resolution rate we've seen in any clinical trial so far. And this was after only 24 weeks of treatment. So we actually did 2 biopsies within 6 months, and we were able to show fibrosis regression in 41%, NASH resolution in 76%, and then 41% of patients were able to achieve both NASH resolution and fibrosis improvement, and about 15% had regression of fibrosis by 2 stages or more, which is really remarkable if this holds, because you can go from a phase 3 to a phase 1 in 6 months after being treated with the efruxifermin. Now, I want you to take these data with a grain of salt, because you can see the treatment arms included only 35 patients. This was only 24 weeks of treatment. There is potential for a phenomenon called tachyphylaxis, where you start losing the effects of the medicine after you use it for 24 or 36 weeks. But, you know, this medication is very promising, and it's actually entering into a phase 3 program, hopefully by the beginning of this summer. Next slide. Okay, the last medication I want to mention is called pemvidutide. I mentioned GLP-1 agonist earlier, but this is a dual agonist. So it has a GLP-1 efficacy in it that will help with weight loss and defatting the liver and hopefully NASH resolution, similar to what we saw with semaglutide. But also it's an agonist for glucagon. So glucagon will mimic the effects of exercise on the liver and increase energy expenditure and potentially help mobilize liver fat in a more direct way, as opposed to GLP-1, which is typically mediated with weight loss. Next slide. So this was a smaller study, and they actually did MRI PDFF at baseline, and then after 12 weeks of treatment, and the study continued for 24 weeks. But I'm showing you data here at 12 weeks, so after only 3 months of treatment. And you can see that with the 1.8 milligram dose, there was absolute reduction of liver fat by 15%, which is very high. If you look at relative reduction, this is at 68%. And I showed you with resmetirom, for example, we're in the 40% range. So this is very high. And then if you look at the percentage of patients that achieved that 30% relative fat reduction, the majority of patients were able to achieve this at almost 95%. And what was interesting also that about 55% of patients were able to normalize their liver fat and have less than 5% liver fat at the end of the 12 weeks of treatment. So this is very encouraging, and we may get to a point where we can start talking about a cure for NAFLD, where you don't have NASH, you don't have fibrosis, but also you don't even have enough fat to call it NAFLD. So we'll see how the future shapes up. I don't think we're going to get there anytime in the near future, but wouldn't that be nice that in the next 5 to 10 years, we have potent medications that can basically cure the disease and not just get it under control. Next. So this is my take-home message. Number one is non-invasive tests are available to all of us, especially the FIB4 index, but ELF is commercially available. There is more access now to ultrasound-based technologies to measure liver stiffness. So we need to utilize these NITs to risk stratify patients, identify those with fibrotic NASH that may benefit from specialty referral. We need to use these diagnostic algorithms. They will help us actually tease out what patients can stay in primary care and which ones need to be seen by us. As I showed you, several options are available today to manage patients with NASH, and I want all of you guys to become familiar with utilizing GLP-1 agonists in NASH patients. I think it's the right thing to do, and honestly, in my clinical experience, it hasn't been that difficult to manage the adverse events, especially if you titrate slowly and provide a lot of guidance. And most importantly, is that new drugs are in late phase development. We have one medication with the FDA now, might be approved in June. The other one could be approved by the end of the year or early 2024. So be prepared for major changes in how we manage NASH. Now is the time to identify at-risk patients, send them to a specialist, and by the time we risk stratify them, we will have medications that we can give them that potentially can modify the natural history of the disease. So with this, I'm going to conclude this presentation. Thank you for your attention and for the opportunity to present